Welcome to this evening's webinar, New South Wales ADHD Reforms, Expanding GP Care of ADHD. My name is Jasmine and I am your RACGP representative for this evening. On behalf of all of our presenters, I would like to make an acknowledgement of country. We recognise the traditional custodians of the land and sea on which we live and work, and we pay our respects to elders past, present and emerging. I would also like to acknowledge any Aboriginal and Torres Strait Islander colleagues that have joined us online this evening. I would like to introduce you to our speakers for this evening. We have Dr. Kerry Chant, we have Dr. Sarah Kanlari, we have Dr. Saran Lovett, we have Associate Professor John Kasanathan, and our facilitator for this evening is the RACGP New South Wales and ACT Faculty Chair, Rebecca Hoffman. I will now hand it over to Rebecca to go through the learning outcomes for today.
Good evening and welcome. It's really exciting for us to get to this point and to be talking to all of our GPs in New South Wales about ADHD. It seems like we've come a really long way in a really short period of time, thanks to many of the people on the panel and on the webinar with us. We have a number of learning objectives that we plan to cover over, keeping in mind that we won't be answering any specific questions about any specific patients that you may see yourself. We're keeping it based to the case studies that we'll be presenting, and I will do my very best to get through as many questions coming through the Q&A with our panelists as we can. I'll answer some as we go and remain some until the end. We are making sure that we've got enough time for all of our Q&As at the end. So to get us off and started, I'm going to pass over to Dr. Sarah, who will take us through the first part of the webinar. Thanks.
Thanks so much, Beck, and I really appreciate seeing so many people here online. It's really exciting to talk more about the ADHD reforms that are happening in New South Wales. I'm Sarah Kanlari. I'm a medical advisor in the office that is leading these reforms. So we know that ADHD has gone through many stages, and because of its genetics and sociocultural underpinnings, it remains a contested area. At least for some, it's considered as overdiagnosed, and by others, it's considered underdiagnosed. And it's an area of epidemiology that has had difficulty generating robust research. The research that exists shows that the expression of both inattentive and hyperactive symptoms have been relatively stable over many decades, but the area of greatest conjecture in the research literature focuses on whether the benefits and the disadvantages of diagnostic labelling and medication treatment in children and adolescents with mild symptoms is truly useful or not. The prevalence estimates vary depending on location. In Australia, we see relatively high prevalence rates, where it's the most common neurodevelopmental condition of childhood. Estimates of prevalence in Aboriginal children and adolescents are not confidently known, but because of the known issues in access to ADHD care, it's suggestive that it's underdiagnosed and undertreated for Aboriginal children. All three first-line psychostimulant medicines are S8 or Schedule 8 controlled drugs, and this is due to their potential for dependence and diversion. While non-medical use is occasionally sought for its intoxicating effects, it's much more commonly diverted for its enhancement of performance and concentration and for weight loss. Within families, it's commonly diverted to treat either ADHD that has been previously diagnosed and, for example, to hold people between scripts, especially during stressful times, or where symptoms of ADHD exist but a formal diagnosis has never occurred. Data from the New South Wales Poisons Information Centre confirms that relative to other Schedule 8 drugs, the harms and adverse health outcomes associated with psychostimulants are rare. There are currently several routes available for people or patients or parents of children rather who are seeking assessment and management for ADHD, but there are clearly significant access issues for many, especially for people who are experiencing socioeconomic disadvantage of all types and people in outer regional and rural communities. ADHD care for adults occurs almost exclusively in private practice psychiatry for adults, and this further compounds the access at transition points for adolescence into adulthood. While co-management and transfer of care arrangements do exist, there are multiple known barriers to this uptake, and we know that uptake has been poor. Independent GP prescribers has existed in New South Wales for a long time in the other designated prescriber workforce, but overall numbers are quite low, as is the geographical spread. Changes to the PBS listing criteria are outlined in the figure shown here. The changes to PBS listings are very closely linked to the increased prescribing of all ADHD medicines, so that's psychostimulant and non-psychostimulant medicines. During 23 to 24, there were just over 4.6 million dispensed prescriptions for ADHD to just under 600,000 people. Around 90% of these were for psychostimulants and around 10% for non-psychostimulants, so that's guanfacine and atomoxetine. Trends of significant increase in lisdexamfetamine and methylphenidate dispensing from 2021 to 23 are very closely linked to PBS criteria that allow retrospective rather than a formal diagnosis in childhood. PBS dispensing data presented here from 2022 to 2024. The next slide, please, Jasmine. By CEFA, or socioeconomic indices for area, shows that the rate of prescribing are much lower in disadvantaged areas with quite a clear linear relationship. In 23-24, dexamphetamine and lisdexamfetamine prescription rates were 2.5 times higher in the least disadvantaged areas compared to the prescription rate for people in areas of most disadvantage. This was similar for methylphenidate. There were smaller differences in the rates of non-stimulant medicines, though these account for an overall very small proportion of prescriptions. I'm going to hand over now to Dr. Kerry Chant, who's going to describe the New South Wales reforms.
Thanks, Sarah. My name is Dr. Kerry Chan, and I'm just going to briefly touch on the reforms. So the New South Wales ADHD reforms were designed to be delivered in 2 phases. In the first phase, which commenced on the 1st of September, GP continuation prescribers are enabled to manage their patients' psychostimulant medicines where they have been previously initiated by pediatricians, psychiatrists, neurologists, and other designated prescribers. The general authority is granted to a prescriber who has completed a course endorsed by the New South Wales Health Clinical Governance Working Group. And I just wanted to acknowledge the role of the relevant medical colleges, the clinical psychology associations, ADPA, community pharmacies representation, and our colleagues at the Aboriginal Health and Medical Research Council, which have formed and participated actively in the Clinical Governance Working Group. Prescribers with a general authority may prescribe psychostimulants for their patients aged 6 years and above, and can change doses within the same drug type up to the current maximum allowable doses under the criteria conditions. This includes switching between methylphenidate formulations, for example, from the immediate release to slow release, and switches between drug types is not enabled under a general authority for continuation prescribers. So far, the Ministry has approved close to 150 applications, and we're encouraging members today who haven't applied to consider their applications. The criteria for the second phase reforms, the endorsed prescribers, has not yet been determined. But based on initial planning, GPs who complete the required training to become an endorsed prescriber will be able to initiate and manage psychostimulant medicines in the same way a pediatrician is currently able to do so, with the normal ways in which general practitioners will refer to other specialists in more complex cases. There will likely be a focus on pediatrics and or adults. Some GPs may do both, but we do recognise that there may be a preference in the age groups, depending on the interest of the GP and the local need. This will be a more limited reform, whereas we see the continuation prescribers being more universal within the scope of general practice. We see that this, because of its more intensive training requirements, will be a more limited group. We will be working with the clinical governance group to identify the sorts of training that is going to be required in order to meet the requirements that we put in place to ensure the accurate diagnosis and treatment. But that will be for later this year. We're expecting to provide more clarity around that initiation, prescribing pathway. So if we now go to the next slide. There's probably just a couple of important things for people to be aware of, and they go to the principles of the eligibility criterion for a general authority. And one of those key principles is that we've wanted this to occur in the context of a holistic and long-term care for a patient. So GPs, rural generalists and registrars of these colleges are encouraged to apply. There's a short online courses required, and these have been assessed as contemporary and practical by the completers. Practice accreditation or working towards accreditation is required, and the intent of this restriction to entry is to support these reforms occurring as part of a full general practice care, like any other chronic condition, and to avoid telehealth and single disease models of care. It recognises the unique and whole of lifespan care that only general practitioners can provide. And just to point that if you don't fit within those criteria, GPs who don't fulfil these requirements can continue to prescribe psychostimulants in a co-management arrangement. Next slide. So as I indicated, the focus of the next 2 months is to ensure that the implementation of the first phase of these reforms are supported and the processes are refined. We're very keen that there is good uptake, particularly in those areas where there may be access barriers. We're really wanting to see this enabled as continuation prescribing in our rural regional areas and also in our Greater Sydney region. The clinical governance working group will work towards determining the requirements of the endorsed prescribing pathway. As I said, this further information is expected towards the end of the year. There are also national processes in play with the health ministers from across Australia committed to working towards a nationally consistent approach for ADHD diagnosis and psychostimulant medicine regulation that recognises the role that GPs play in delivering holistic care. And we're very mindful of the benefits in a national approach, and we will be mindful of trying to get that work towards a nationally consistent approach. So we welcome your feedback through your usual college channels, or you can contact our ADHD team reforms on the reforms email. And at this point, I'm going to hand over to Wes Scaife, who's from our pharmaceutical regulatory unit in the Ministry of Health, to take you through some practical steps for your psychostimulant prescription. So over to you, Wes.
Great. Thanks, Dr. Chat. As Dr. Chat said, my name is Wes Scaife. I'm currently the Acting Director of Pharmaceutical Operations, and today I'll be discussing the prescribing of these Schedule 8 psychostimulant medicines. So for those of you that are wondering where we, I guess, fit in this whole scheme of things is through the administration of the legislation that govern medicines regulation, and specifically the ones are Poison Therapy Goods Act 1966 and the Poison Therapy Goods Regulation 2008. And as you've heard from Dr. Canalari, these are Schedule 8 medicines, and they do have additional requirements around their prescribing. Next slide, please. So prescribing psychostimulants in New South Wales are currently under very stringent regulatory controls. To be able to prescribe these in New South Wales, prescribers will need prior written approval from the New South Wales Ministry of Health, given that they're classed as Type A Schedule 8 medicines. This includes CA 2023, which we allow or have issued for as a class authority for psychiatrists, pediatricians, and neurologists. CNS or S28C, which is kind of outdated, but still used by some specialists that I've just mentioned above. and then the A or AU number, which is the current individual patient approval numbers that are issued to specific prescribers for a specific patient. And then finally, and the current focus of today, the GACP number, which is a general authority issued to a specific continuation prescriber, allowing them to prescribe Schedule 8 psychostimulants with the individual approval provided to them. Next slide, please. So now onto the legal requirements for psychostimulant prescriptions here in New South Wales. All the prescriptions to comply with the New South Wales legislation, prescriptions will need to be endorsed with a date issue, a prescriber name, address, and contact number of the premises, the patient's name, address, and date of birth, name, strength, and quantity of the medicine to be dispensed in numbers and words, the numbers of repeats, if any, and then the repeat intervals, adequate directions for use. For psychostimulants, a New South Wales Ministry of Health approval reference number, and again, the focus today will be for GACP, a signature, and then the only other disclaimer or consideration is that only one medicine is allowed on these prescriptions, with the rest of the prescription needing to be scored out. So in terms of handwritten prescriptions, there are 3 current approved scripts, for lack of a better word. They include handwritten prescriptions, which we don't really see much of from general practitioners. There are computer-generated prescriptions, but also the new electronic conformant prescribing software issuing electronic prescriptions. In terms of handwritten prescriptions, all of those that I've just mentioned need to be handwritten by the prescriber issuing the prescription. For computer-generated prescriptions, generally the name and the name of the medicine and the preparation it contains, including the strength, when one or more strengths available, the quantity prescribed in both words and numbers, the adequate directions for use, and the number of repeats authorized, if there's more than one, and repeats, the repeat intervals will need to be handwritten, and then obviously hand-signed. For electronically conformant prescriptions, there's an exemption to not require any of these to be handwritten. There will be a need for those prescriptions, however, to be endorsed or include the GACP number for those GACP prescribers. Some prescribing software, I've been advised, has a designated field where this information can be entered. For those prescription software that doesn't have that capability, we do suggest or advise prescribers to issue it in the free text field. We don't really specify where it needs to be included, as long as it is included on the prescription. And we have communicated that to community pharmacists to make sure that when prescriptions are issued to patients and them going on to fill those prescriptions, that they are aware that these requirements are, I guess, covered under our requirement here in the legislation. And that's pretty much it. Thank you very much. Oh, sorry. I will be presenting just example scripts. Apologies. The first example is a handwritten prescription, which includes the particulars of what I've just mentioned as a legislative requirement here in New South Wales. So as you can see, most of those entries that I've just mentioned are all in the handwriting. The GACP is included on the prescription on the middle right-hand side. We have repeats and repeat intervals listed. And then we also have the prescriber's signature there towards the bottom. The next example is a computer-generated prescription. And again, as I've mentioned, the information that needs to be handwritten is pretty much in the body of that prescription. And again, it includes the medicine and the strength, the directions for use, the quantity, the repeat, and the intervals, and then the doctor's handwritten signature. The GACP is also included, although that's not really required to be handwritten. It just needs to be included on the prescription. Next slide, please. Great. I think that's pretty much it. Thank you very much for your time. I'll be introducing the next speaker, Dr. Saran Lovett. Thank you.
Evening, everyone, and thank you, Wes, for my introduction. Thank you for having me this evening. For those of you who don't know me, I am a general and developmental paediatrician based in the Hunter region of New South Wales, and I am also currently the Vice President of the Australasian ADHD Professional Association, which has been part of the rollout of these reforms, but also the development of some of the guidelines that have informed the changes in ADHD care across Australia and New Zealand. Today we're going to take you through a couple of case studies, and as a paediatrician, they're going to be paediatric based. So case one is a young 9-year-old boy who presented with concerns around attention, with a background history of some hearing issues, requiring grommets at 4 years of age. He was experiencing some expressive and receptive language delays for which he was receiving speech therapy. At school, he was described by his teachers as a gentle giant who feared failure. He would often become quite defiant when things got too hard. They stated that his academic abilities seemed to fluctuate from day to day and he wasn't very consistent in his learning abilities. At home, he was a kind but forgetful sibling and needed more support than his sibling who was 3 years his junior. So there had been historical reports from his teachers that attention was a concern within the classroom from grade 1, and he'd often received the comment that he was off with the fairies. They also described on some ADHD questionnaires that he had some difficulties with his organisation skills in the classroom and also sustaining attention, particularly with non-preferred tasks. He was often distracting himself, distracting others, or distracted by others. He struggled to follow instructions and he often made silly mistakes with his works. There were no other social communication difficulties and no restricted and repetitive behaviours suggestive of an ASD diagnosis, and there was no other sensory difficulties. His sleep was normal after he had adenoidectomy, and so there was no history of snoring. He was waking up with energy and he had no delayed onset. He had some mild constipation, but thankfully his diet was quite robust with, I'd describe a rainbow diet being eating all the colours, which many children don't. And importantly, he was eating at least 3 servings of red meat a week, which I seem to find anecdotally that is what a child who is growing needs to have to maintain their ferritin in the normal range. His examination was essentially unremarkable. He had appropriate growth parameters and his blood pressure was normal. The family history was a little bit suggestive, with mum having some neurodiversity with some depression, but was working well in managing a practice for a surgeon, and dad was a construction worker who had a diagnosis of dyslexia and did admit to difficulties with attention at school and finished school at year 10, but there was no formal diagnosis. So now I'd like you guys, I think there'll be a poll popping up, and it was just, can you guys pick your main concern for progressing forward with this young child if they presented in your rooms?
Lots of responses coming through, Sarah. Might just give it a few more seconds. Okay, we're going to end that one here.
So I think I can see the results. I'm not sure if you guys can. So more than close to 60% of you identified the inattentive symptoms of the child as your main priority of concern. And then the family history of ADHD was second, third was hearing concerns, and last was speech concerns. And I guess I put them all up there. They're all relevant. They're all something that we would pay attention to. But I guess if the family are coming, and the main priority of this consult would be further addressing the inattentive symptoms of the child. Thank you. So what would be your next steps to do that?
Lots of responses coming through for this one. Give it a few more seconds. Okay, we might stop this one here.
Okay, excellent. Fabulous to see these responses coming through. So about 90% of you felt that further investigating the ADHD symptoms both at home and at school was an appropriate next step, and possibly to do some baseline blood work with a nutritional screen. That was about a third of you. And then the next most common one was the cognitive assessment and the learning needs assessment. So obviously we need to do some more fact finding and information about those symptoms of ADHD, both at home, at school. Other places that you can explore that can be in the social environment as well, so in the playground, but also with sporting teams, dance places, wherever a child is doing extracurricular activities. It can be really useful to get an idea, because it's not necessarily the home or the school academic environment that ADHD will show itself. It can also be their social and emotional places that you'll get those keys to supporting the child overall, and it also makes a better holistic picture. With regards to baseline blood work and nutritional screen, often it is a nutritional concern that I have for the child to progress down and doing bloods, because doing bloods in kids, none of us ever like having to ask family to organise that. It's rare that I will do just baseline screening on a child who solely presents with ADHD. If I have a significant concern that there may be some other neurodevelopmental diagnoses such as autism or intellectual disability, I will often add those in. And really the threshold for my nutritional screen is that question around red meat. So if it's less than 4, they usually get a screen to check their iron plus their celiac screen at the same time, so that you don't have to go back and poke them when their iron comes back low. Next question, please. So I've put up these sort of questions around, or information around, the cognitive assessment for the WISC-5 and the WIAT-3, which is one of the learning needs assessment options that you can organise through a psychologist. Now, it's important to realise that these don't actually add anything to a pure ADHD diagnosis. They are very useful to understand how a child's brain works, how we can teach to their strengths, and what their strengths and difficulties are within the learning environment. But they don't actually evidence-based add to a diagnosis of ADHD. ADHD comes down to a good, thorough clinical history that focuses on the DSM-5 criteria to be accurate, to look at how often the symptoms occur and how they impair the child or the individual in the world of adults. So even a Connors 4, which I've got the screenshot of there for this particular child, it's useful, but use all of the ADHD questionnaires and assessments as a conversation starter. You can, often as a pediatrician, I will have a child who comes to see me who's already had a psychology assessment done, and they may have had a Connors like this. I will not use that as my sole, yep, this child has got ADHD. It's about using this information to then validate for me that this little person, yes, experiences very elevated symptoms in inattention, but how? What are the examples? How often are they occurring, and how do they actually impact the child? Because we all forget our keys and phone, like I did today at work, which was rather annoying because I couldn't do my PROTA secondary verification. So it all happens, but what is the impairment to the individual, and does it cross those environments? So having done that with a good, thorough clinical history, the summary of this little person is that he is a 9-year-old boy who presented with attention and speech concerns. And he did display on history 6 out of 9 of the inattentive DSM-5 criteria, and these symptoms impacted him both at home and at school. His cognitive assessments showed that he had an average IQ. However, he did meet, like his father, a DSM-5 criteria for a specific learning disorder in reading, also known as dyslexia. So next slide, thanks. So to support this young person, we've progressed down the pathway of commencing a trial of stimulants. And I commonly start methylphenidate in my primary school age children because I do find it's a little less activating than dexamphetamine. Dexamphetamine affects the release of dopamine and noradrenaline a little bit more. And so some children can find that a little bit hard to cope with, but it doesn't mean it's not the right thing to do. There's evidence that both one and the other will work just as effectively. So this is my typical starting protocol for a child, and I know we're talking mostly about continuation of prescribing here, but this I'm sure is a question and something that's useful for all of you GPs to sort of just have an idea of what we do in practice. I go up slowly. I go up every week because if I was a parent, I would like my child to be at home for 2 days when I increase the dose. So I always start on a Saturday and then they have at least had 2 days of each dose step at home before they go to school, where the teacher is then the only person who's dealing with the side effects. I think that's a bit unfair. And also parents need to know what's happening for their child. They need to see how the medicine is affecting them. So that's my little spiel there. So the trial was successful for this young person. He had an overall good response with no major significant side effects. There was the feedback from home that he had increased independence at home with his chores, and he was getting ready for school more independently. He had better relationships with his sibling. And at school, these teachers could see that he was able to engage with tasks that he previously found really challenging. And that's one of the key things I see as a pediatrician that's really amazing. I've often had kids who have really, really wanted to learn to ride a bike, and it's just all been too hard. And then we start stimulants, and the next time it's like, I can ride a bike, Dr. Lovett. It's really lovely. So things that you don't necessarily would expect to see as a benefit of starting these medicines, we think very often sort of with the blinkers on, we've got to see improvement in academics, and it's a holistic disorder, and therefore the medicine should be helping the child in a holistic manner as well. The side effect of not eating lunch, I warn all families, that's going to happen. It's the one thing that's pretty universal, and so making sure that they eat of an afternoon and get those calories in is important. His weight dropped 1 kilo, which is to be expected. I often warn somewhere between 1 and 2 kilos. And there was thankfully no impact on his sleep. And he was a little bit emotional at school pickup, which is quite common on short-acting stimulants. And he also really wasn't a fan of having to go up to the office taking the medicine at school. So what would you do next?
While people are looking at the poll, I might ask the question that just popped into the poll, because it was one that I was going to ask you next anyway. When do you talk about non-medication options? At what point across this case study would you have those conversations?
So I would have that conversation when I am delivering my diagnosis. And I usually sort of explain the multimodal management of ADHD, incorporating those non-pharmacological management strategies, which are really thoroughly outlined within the ADPA guidelines and form a large part of the RSAGP training modules as well. They definitely are very useful but we know that the evidence says that for treating the 3 core symptoms of ADHD, hyperactivity, impulsivity, and inattention, stimulants have the best efficacy. So it's really important to remember pills don't teach skills, but they do help you learn them. So if you can focus and attend to pay attention to learn the skill, then you may be able to implement it. But pills by themselves don't teach skills, and that's where the multimodal psychosocial side of managing ADHD really comes to the fore.
You just mentioned the guidelines. For people who don't know who were on the webinar, what are these guidelines? Where can they be found? Do you mind giving a quick, just a brief?
Sure. So I have, this is, so, oh, you may not be able to see. That doesn't work well. So ADPA guidelines have, they were released in 22. And they are a national guideline which looks at the evidence and it gives you an outline of how to approach an ADHD diagnosis and how to manage it. All of the guideline is available electronically or in a hard copy, which is available on the ADPA website. And also alongside that is that lovely green shadowy book that I held up, which is the ADHD's prescribing guide, which we released last year during ADHD Awareness Month in October. And it is a fabulous companion for anyone who is prescribing in the ADHD world. It's all evidence-based. It has some fabulous frequently asked questions. It has information across the lifespan. It has questions about cardiac complications, management, titration protocols, menopause, a lot of the mental health things that you will see in the ADHD world and GP world that co-occur. So it's an incredibly useful document, and it's available both in hard copy and an electronic one. And the electronic one's lovely because it's got links and you can just click on what you think is a frequently asked question and you'll jump straight to the part in the guide. So excellent. So yeah, about 60% of you have suggested to swap to long-acting preparations, and then about close to 40% of you considered just continuing the current management, and then the other options were a little bit less. Adding in calories, if you were to continue the current management, do some high energy eating would be totally valid. I guess the thing that might sway you to trialing the long-acting is the fact that he is 9 and he doesn't enjoy going up to the office in the middle of the day. The other thing that's really useful to recognise is that in practice, because the short-acting medicines are a quick on and they're also a really quick off, I often talk to families about when you're on short-acting, it's like walking off a cliff. And when you're on long-acting, it's like walking down a hill. And if you think about the cognitive load and the emotional load that you're sort of holding together during the day at school, it's really common for the pickup time to be like you've got a tired, hangry toddler who doesn't know which way is up. And that happens quite abruptly on the short-acting. It usually gets better after sort of 8 to 10 weeks on the medicine, but it can be rough for some. And so if the medicine's working really well during the day, but the emotional sort of side effect continues, then those are the kids who do really well by swapping across to the long-acting. Thank you. Next slide. So I did swap to long-acting. It worked really well with his emotional fragility in the afternoons, and it was great that he didn't need to take the medicine at school. With the longer acting ones, obviously the tail of the medicine is a little bit, it's there for a bit longer, so you've got to check on sleep onset, and also the longer it works for, the longer the hours of appetite suppression, and so just monitoring that weight is tracking well. I wanted to put in this graph again just to talk to it, because this is the graph, the archetypal graph that I love to see on my children that I'm caring for with ADHD, because I always talk to the family. You start on 1 percentile, and then you drop to the next one, and then you track up, and then they grow, and then we probably increase the dose at about 12, and then you drop down a little bit, and then you tick up. So as long as you see that uptick, that's a very normal, healthy ADHD response. So this,
Before we move on to case 2, can I just ask a follow-up question about case 1 and allied health? What would your suggestions be in regards to allied health and continuing on for this child? Do they need to keep doing their speech therapy?
So this young boy definitely did require some support around speech therapy. He did have his speech report showed that he had expressive and receptive delays, and speech therapy can be useful in in parallel with children with dyslexia to be able to help them formulate and build their language base. So yes, I would say that would be a useful thing for this child.
And I have a question in regards to the dosing during the day, because that can be quite tricky when they're leaving the classroom or having to time around breaks.
Yeah.
What do you recommend for your patients? Do you recommend they try and time it around breaks between classes, or that the teacher sends them up mid-class is a more successful option?
The more successful option is making sure that there's no gap in the middle of the 2 doses. So I think 3.5 hours, because the half-life is about 4 hours, you have your morning dose roughly at 8 o'clock. I write a letter that says, please organise for them to have their second dose at about 11:30. You want the morning dose to be starting to taper off, but not have bottomed out, because otherwise you're just meaning that this little person is going to go back to their baseline ADHD, they're going to get in trouble, you're going to have negative side effects, and you're also making them dig themselves out of a hole for the afternoon. And so it's definitely better to try and overlap the 2 doses so that you get fluid cover throughout the day.
And how does that work around things like inflexible mornings, like if they've got swimming training before going to school, or if they've got PWSA soccer all morning on a Friday? What strategies do you use for families to juggle random events, or non-random but differing events?
Yeah, so extracurricular activities are a really common thing. It is it's a multi-pronged approach. Is the dose of the stimulant impacting their weight often too much to be able to allow you to medicate for the extracurricular? And so obviously where the goal is to improve school, because it really is 8 hours of cover for most kids. And so the biggest bang for your buck, for benefit for the child, is the social and the learning that happens at school. So if weight is just teetering on the edges, then you probably can't add in a small dose depending on where the extracurricular activity occurs. Sometimes there are children who have got a bit of a buffer and they can tolerate a little bit of extra short acting at the shoulders of the day. And that can be useful for morning activities. Often it's an afternoon activity where around 3 they can have a third dose of say 5 or 10 milligrams, depending on how old and how big they are, and that will get them through till about sort of 7 o'clock, and you'll have the ability to eat dinner and get all of their extracurricular activities done in the afternoon with that extra support. So that's useful for homework, for tutoring, and all of the sports and other activities, and the social stuff that comes along with those sporting activities. Because if they're not enjoying, or they're kind of on the outer in a team sport, you don't want that either.
Thanks.
It's also a place spec for non-stimulants, so the addition of guanfacine in there as well, to support the shoulders of the day while you've still got really good cover for the school hours. So case 2, this one is to highlight that what and I'm sure you, as GPs, I'm preaching to the choir, what walks in the door isn't necessarily the simple person that you expected, and over time it gets more complex as things evolve. So I met this young 9-year-old girl a few years ago with an Indigenous background. She had known when she already came to see me, had known chromosomal duplication, which is the same as her dad and her sister. And her parents were concerned that there was some dysregulation at home and school with her emotions, and she was struggling. She was in year 3 and only on a level 19 reader. And for those who don't have a concept of where a little person should be, by the end of year 2, you should be around a level 20. So she's a year above and still sort of sitting at a year 2 level. Struggling academically, had changed schools and was repeating year 3. She was pretty hyperactive. The feedback from this new teacher in this new school was she just can't sit still, heaps of fidgeting, talking constantly and getting distracted, and again, giving up easily with tasks. It was hard to have a conversation with her because she had quite disjointed storylines, and it was hard for her to keep track of her ideas and what she was talking about. There were lots of meltdowns at home when her expectations weren't met or when change occurred. And she did have some sensory issues. She had quite some restricted interests around dolls and the routines around putting them to bed each night. She was able to initiate friendships, but maintaining them was pretty tricky because she often liked the play to go her way. She had some repetitive phrases, some phrases from some movies that she would insert into conversations. She would often ruminate over some of the topics, and at times when she was quite stressed, she would revert to a baby talk and tone. She's a pretty bendy and hypermobile little person. Sleep was already challenging by the time I met her, and her family had commenced her on some melatonin. She snored only occasionally and woke up happy with energy. Her diet was pretty restricted and definitely wasn't a rainbow and didn't have a huge amount of red meat. From her background history, her mother's pregnancy and delivery and early developmental milestones were essentially unremarkable. Next slide, please. Her family history did tell a fairly important story. So mum is a 30-year-old stay-at-home mum who finished school at year 11. She's completed a TAFE course in childcare. She had PCOS, for which she was on metformin, and had some sertraline for a diagnosis of OCD. Dad was 33. He finished school at year 10 and was a hydraulic hose fitter. He had significant mood swings still as an adult and used alcohol to manage those, was mum's words, and he found it really difficult to maintain long-term relationships with his family and friends. He changed his jobs multiple times. As I said, he had the known chromosomal duplication, and he had a sister who had a formal diagnosis of ADHD. His parents, this young girl's parents, were separated. They did have, she had another sibling, 12-year-old, who had the same duplication, which for her was markedly affecting her life with precocious puberty and some other medical conditions. And she was in a multi-category class with an autism diagnosis locally. When I first met this young girl at 9 years of age, her weight was 29 kilos on the 50th centile, height of 130 on the 50th centile, BMI on the 50th, and her overall exam was relatively unremarkable, except she did have slightly enlarged tonsils and a bit bendy with her Bateman score of 7 out of 9. So what would be your two main burning questions here?
Lots of responses coming through for this one. Just give it a few more seconds. Okay, I might close this one off now.
Great. So there's some concerns about an autism spectrum diagnosis. About 3/4 of you suggested that. There's concern about the genetic diagnosis and a possible underlying ADHD diagnosis. There was also a smattering of the others as well. Excellent. We'll move on. So this young girl with appropriate investigations was given a diagnosis of ADHD of a combined subtype and had a good response initially to methylphenidates short acting, and then we swapped her across to longer acting methylphenidate, and I did refer her off for autism assessment. The feedback from the teachers with the stimulant trial was really positive, heaps of improvement within the classroom. She was willing to work, she was less distracted, and home was seeing a marked improvement in her emotional regulation. And I know that this is quite small, but if you're used to seeing NAP plans, you're just looking at the little tiny dot. So the first one at the top is year 3. You obviously don't get this often, but year 3 at her old school, and then year 3 at her new school. And there was a marked improvement in her scores, which was nice to see. As she progressed, she had recurrent tonsillitis, and so I made a referral to the local ENT, which locally takes a very long time in the public system. She also complained of recurrent mouth ulcers, and she was pretty bendy, but starting to complain with of sore joints, lower limbs, sometimes keeping her awake. And the stimulants had affected her sleep onset, and she was already on melatonin when we started. Her appetite was markedly affected and she wasn't eating lunch. And with her restricted diet, her weight did fall quite significantly, from 29 down to 26.6. So her weight was now on the 5th to the 10th centile, and that made her BMI down on the 5th to the 10th centile as well. Mum also commented throughout this time, because obviously this was not immediate, this was over probably a couple of years progress. Mum had ended up with a diagnosis of ulcerative colitis for herself as well. Next slide, please. So now, as we're progressing, what are some of your new concerns for this young child?
We'll give it a few more seconds. Okay, I might stop this one here.
So that's a good spread, and the spread that I would like to see, so great job. So the 3 most concerning features of this presentation and the progress were that the stimulant side effects were affecting her appetite and her sleep, the possibility of an evolving autoimmune disorder, and the fact that her weight loss and her BMI were now on the 5th to the 10th centile, and then the other options were part of the lower one, so that makes sense. Excellent. Moving along. So this is how I try and think about it from if I were working in a co-prescribing sort of co-management prescribing situation as a GP. So obviously we've got green flags. She's doing well on the stimulants. The emotional regulation has improved, but we are starting to see quite a number of amber warning signs. Her sleep onset has increased. We've got some other sort of medical concerns that are going on here, and she does sort of definitely meet the criteria for an avoidant and restricted food intake disorder. We have the big obvious red flag that her BMI percentile has dropped multiple from the 50th down to the 5th to the 10th. So this is definitely a child that a pediatrician would be more than happy to see, and I would hope you guys would be wanting some extra support to sort of manage the complexity of this young lady.
Can I ask a question from the chat specifically around
Yeah.
weight? If their starting point is already the 5th to the 10th percentile, or I guess conversely, if their starting weight is in the 95th to 100th percentile, then for both of those groups, what are your thresholds that you're wanting re-referral back for?
Yeah, really good question, and something that we delve into some of the red flags and information that we'll have available for supporting this model. But my practice and many pediatricians is if I've got a child who's already on the 5th to the 10th centile for before I'm starting stimulants, I have a very strong conversation with the family that this is going to be a very cautious trial, that we are going to closely manage their weight with high energy calorie eating and give them advice, often proactively refer them to a dietitian as well to help get those calories in. If they're the 5th centile, I am often already commencing a non-stimulant as my first line, because I think the potential to do harm in that particular population is really high, especially if I've got a young person who has a diagnosis of ARFID in the context of an autism diagnosis. It's incredibly hard to calorie load those kids as safely. Conversely, on the other side, the young people who have got BMIs sort of 90th centile and above, I do not expect them to lose weight on a stimulant. It is quite rare. It's the kids that you don't want to lose weight who do, and the kids that you do want to lose weight who don't. So I think, look, you would be referring those kids for support because of their BMI for other reasons, for obvious reasons, with or without the stimulants. I don't think it is a rare child who is overweight who on stimulants loses a significant amount of weight.
Thanks.
So in this young child, I think we've all sort of come to the conclusion that her BMI drop is multifactorial. And so the things that I had to consider as I was working with this young person over time was, yep, the methylphenidate is having an appetite suppressing effect, and we do have ARFID, so that's challenging. But we've also got recurrent tonsillitis, and this young girl's pain threshold was very low, and she found it very difficult to manage her oral intake when she had tonsillitis bouts. And so I was making re-referrals back to the ENT to try and see if we could expedite that intervention. And then the mouth ulcers were incredibly painful and huge. And so I sort of was thinking, gosh, have we got a young child who's got an autoimmune inflammatory bowel disease given the family history? So the parents and the child were very keen to continue the stimulants. And again, it was all around making sure that the high calorie eating was happening. And we organised for a dietitian review. She had a really fabulous end academically of the school year. And she was already on the ENT public wait list, which I was trying to speed up. Her autism diagnosis was confirmed, and so we were able to put in extra supports now that we had some NDIS funding, and we commenced a trial of clonidine to see if we could help with her sleep delay. Next slide, please. So this is the graph that is really challenging to deal with and would be something that we would want you guys referring back or having really vigorous conversations with your non-GP specialist about. The bloods for this young lady, ferritin surprisingly was in the low normal range. She didn't have any obvious inflammatory bowel markers on bloods, but she did have a high T to ANA. We commenced her on a slightly decreased dose of methylphenidate with some guanfacine, which helped with her ADHD symptoms, but unfortunately coincided with some really significant bullying and some school refusal, which led to quite significant co-occurring low mood and thoughts of self-harm and suicidal ideation. And guanfacine can sometimes do that. And so the coincide was pretty sure it was mostly school and environmental, but the fact that the guanfacine was commenced at the same time led to us ceasing that. And we didn't go back up on the dose of the methylphenidate because of her weight. And we just had to live with suboptimal ADHD management for a time. Due to the recurrent mouth ulcers, she wasn't able to tolerate the increased calories. The anxiety and the bullying continued, and with the low mood, we commenced some fluoxetine as well. And in amongst all of this, she did end up seeing the gastroenterologist locally and had a scope, which diagnosed a microcolitis for which she was commenced on methylsalazine. And so we were in this sort of limbo of let's see what happens and hope that the management of the inflammatory bowel disease allowed us to be able to more appropriately manage her ADHD. Next slide. Unfortunately, that was not the case. So it all coincided around COVID, of course, and the complexity of this young lady around school refusal, and bullying that was happening inside and outside of school on both social media and just at local shopping centres and things with other kids, meant that her anxiety increased significantly, and by the end of year 7 she was refusing to go to school at all. At this time we also were in a situation where we're at home, we could do learning at our own pace, and we had a bit more support in the environment. So we stopped the stimulants, and the homeschooling commenced. And you can see that massive increase in her weight there with stopping the stimulants. So obviously there was an overlay of stimulants that I just had underestimated how significantly it was impairing her overall ability to maintain her weight. At home, once we'd sort of stabilised, we did recommence on ADHD management, but we trialled some atomoxetine, which gave her quite reasonable support for her ADHD. And as she was already on fluoxetine, it's my practice, I always do an ECG as a baseline to check the QT interval, and then repeat it in about 6 to 8 weeks once they're on a stable dose of the second agent. Overall, homeschooling continues, part-time job, has a boyfriend, and has a goal of completing vet nurse through TAFE. So a good end, but it was a really rocky time. So again, this is not an exhaustive list of the amber flags and red flags, but they're focused on this particular case. But essentially, as a paediatrician who's engaged in co-management care, I am always happy to take a phone call, and I am more than happy to try and make space to see a child when needed. I think they've been my child, and the reciprocal nature, and there is going to need to be collegial support of both sides of the coin in this model of care to make it work well. And so don't feel that asking for help or sending a complex child or a person who becomes more complex that was unexpected back to us, we're more than happy to do that, because I know that together we'll share the load and it will be helpful. Thank you.
Thank you so much. They're two incredible cases, and we're now going to pass over to Dr. John to take us through some additional case studies. I'm apologizing, I'm talking fast because I asked way too many questions, and so we're speeding through to Dr. John's slides.
Thank you very much. My name is John Carsinathan. I'm a child and adolescent and general psychiatrist and a forensic psychiatrist, and I work in both public and private sectors. Thank you. So I'm going to talk about two cases. The first one is about a young person who's transitioning from pediatric care to adult care, and this is all based on a real person. So it's a 17-year-old Caucasian female who presented with her mother for a continuation of their ADHD treatment. She lived with her mother and her younger brother who had autism spectrum, age 12. They separated as a family unit from the father 3 years ago because of quite extensive domestic violence. The mother and father both were police officers, and it sounded like a pretty horrific situation, but this family fled. This patient was prescribed lisdexamphetamine 50 milligrams and sertraline 100 milligrams daily. They first saw a pediatrician in 23, diagnosed with the inattentive subtype of ADHD and were treated with dexamphetamine initially, and then moved quite reasonably to long-acting lisdexamphetamine from 2024. In 2024, they were seeing a psychologist for what was felt to be obsessive compulsive disorder. They also were noted to be self-harming by cutting weekly. There'd been 5 overdoses on the prescribed ADHD medication. 3 of those had required emergency presentations. So you're getting a sense that this isn't just a simple case of it's ADHD, please continue medication. They'd seen the Child and Adolescent Mental Health Service earlier this year, who had added sertraline, but deemed, and you guys might see this as much as I do, that they don't have a severe mental illness, and so they're not going to be looked after by the public mental health service, which is a darn shame. But anyway, it's left in your lap, or my lap. And these were the concerns the mother had. The child had extreme distress at times, like out of keeping with any kind of reasonable responses. They were only showering weekly. And there was an odd reason for this. It was because she believed she had to wash all the bed linen and couldn't possibly shower and go into a bed that hadn't been washed. She wouldn't flush the toilet, and her rationale for that didn't seem very clear. She washes her hands constantly. She believed people were watching her. She believed people could read her thoughts, and she was unable to attend school for 2 months. Thank you. Next slide. So what would you ask this young patient next? And just select 2 options from the list. I often find that young people may not tolerate an interview with me for very long. I tend to be rather blunt, so maybe my interviews are shorter than most. But I sometimes think I need to go for the information that's really crucial. So what would you ask about next? Just pick 2, and we'll close it when we get enough responses. Rebecca, happy to take any other questions that might be in the chat that are relevant if you have any, but if not, we'll just wait patiently.
I think I'll say the ones that are there at the moment, but I like the bluntness. It's a lovely strategy.
It's cleared many waiting rooms.
Give it a few more seconds.
Sure. So tell me about ADHD, tell me about being watched, tell me about self-harm, tell me about drugs and alcohol. What are the 2 most important out of them?
I'm going to close this one now.
Thanks. And I should say all those options are pretty reasonable. And pleasingly, 2/3 of you have picked tell me about being watched, and another 2/3 have said tell me about self-harm. nearly 50% said, tell me about drugs and alcohol, and 1/4 said, tell me about OCD. I would have picked, tell me about being watched, and tell me about drugs and alcohol. Let's go to the next slide. Thank you. So that's what I explored. And what had happened, the girl, when I got her individually, was telling me for 18 months she'd been getting worsening feelings, that people were watching her through television, through cameras. She believed that there were cameras on TVs. So she was watching Netflix. She believed that they were sort of watching her as well on iPhones and iPads. She also started to believe that people could read her thoughts, that thoughts were inserted into her head of bad things happening. And it's possible that that was construed as OCD by the psychologist sometime prior. Her mood was described as oscillating from sad to angry to nothing, meh. She had poor concentration even on lisdexamphetamine, and that was interesting considering that was prescribed for concentration and ADHD, and she was disengaged from school. And it seemed that these above symptoms were really impacting on her. Drugs and alcohol is a really important area to cover with any adolescent and young adult. So she was drinking about 4 standard drinks a week. That's not too alarming. The acid was a bit alarming. Mum didn't know about that. And she was smoking cannabis, which Mum did know about, and was smoking 1 gram every day, and an ongoing basis. Thank you. Next slide. So on mental state examination, she appeared to be an overweight Caucasian female, about 115 kilos, according to my weighing scale. It's a psychiatrist weighing scale, so it may not be that accurate. Her affect, interestingly, was blunt. It wasn't just flat, it was blunt. It was like hardly any responsivity at all. Really upset mood. Thought form was normal. Now, in terms of thought content, she had intermittent suicidal thoughts. No specific plan to suicide, and she wasn't homicidal, but she did admit to these delusions of being watched and monitored. She also believed that she was getting contaminated by germs, and not in a classic OCD sense. This felt like it felt to me to be a delusional level of contamination belief. And she also had the Schneiderian first-rank symptom of thought alienation, including broadcasting and insertion. She didn't have hallucinations. Sorry, that's meant to be OH for olfactory hallucinations. There might have been a visual hallucination of shapes changing when she looks at walls. She had partial insight and was accepting of treatment. Thank you. Next slide. So what's the diagnosis now? Please select what applies the most. I think you can have up to 3 correct answers here. So is it ADHD, major depressive disorder, first episode psychosis, obsessive compulsive disorder, alcohol use disorder, cannabis use disorder, factitious disorder, or borderline personality disorder? Oh, there's only a single choice. It's meant to be 3.
And so I guess, are you wanting the one that we're most worried about or the one that's most likely? What are you hoping?
It was meant to be, it was meant to be the 3 diagnoses that apply. Yeah, sorry, that got lost in translation. So pick the one that you're most
Apologies.
worried about. No, it's fine. Pick the one you're most worried about, and we'll go from there. But also pick 2 others because we'll discuss them after it closes.
Just give it a couple more seconds.
Sure.
There was a question previously about upskilling in other non-ADHD diagnoses, things like ASD, psychosis, OCD. Any suggestions for where GPs can go to upskill in non-ADHD?
I mean, look, psychosis is really important to upskill. I mean, I would actually just review a good psychiatry textbook. Like, you get these nice summary textbooks that medical students use. They're actually quite useful because they summarize, key content. Autism spectrum disorder is a clinical diagnosis, and there are trainings that are done in terms of helping with that. Okay, results are in. 2/3 have said first episode psychosis. Oh, you have made me so happy, because I really worry about this sometimes. And then we've got a smattering of the other diagnoses, and 20% highlighted the cannabis use disorder. Yes, so just if we go to the next slide, the most relevant diagnoses are first episode psychosis, absolutely number one. Cannabis use disorder is obviously there by the patient's own self-report, and ADHD inattentive type. So that's really what came into my office. Now let's go into the next slide to look at what our management will be. So here you can select all that apply. What will your management be? Will you increase lisdexamfetamine, decrease it, stop the stimulants, switch to methylphenidate, start aripiprazole, avoid talking about cannabis, do some motivational interviewing around the substance use, and consider non-stimulants for ADHD. You can select all the ones that you think are important there. I would pick 3. I'll give you some time.
In general practice, sometimes I have a rule where I only like to do one thing at once. In cases like this, where you may be worried that they're potentially not going to come back, well, how many things are you happy to do in one visit?
Well, I would do 3 in one visit. 3 of those that are listed there, and hopefully that we'll see what our colleagues say online. Yeah, I would do. I would do 3 that are on that list, and I think that's reasonable for a one-off, and hoping that they do come to follow up, because this one's a bit more complex. Then please continue my child's ADHD medication.
There's just a reminder in the chat that GPs in New South Wales do have access to their GP support line, the phone number to contact a psychiatrist in business hours if you're needing some additional support. So we'll make sure that that link and that phone number goes out as well.
Okay, results are in. 6% said increase lisdexamfetamine, 15% said decrease it, 50% said stop stimulants. That's the right answer. 7% said switch to methylphenidate. I wouldn't advise that. 75% said start aripiprazole. Excellent. I definitely think she needs to start an antipsychotic. That's crucial, life-saving treatment. I'm glad very few avoided talking about cannabis, and 60% said do motivational interviewing, and 66% said, or 68% said consider using a non-stimulant. And that's, if we go to the next slide, please, that's really what I think is crucial in this case, is that the treatment of psychosis is really essential. Now, it's possible it could have been precipitated by the lisdexamfetamine, or it could have been precipitated by cannabis. There might have been a genetic component to it, or a combination of all those 3. We really need to stop the stimulant here. Stimulants increase dopamine in brain pathways that are involved in concentration. They also increase it in the limbic system, and that will make psychosis worse. Motivational interviewing makes sense. And once the psychosis is treated, I said consider a non-stimulant. I didn't think to put them on it immediately at that first session. I would have done that in a follow-up appointment. And there are 3 options there that I've said. And I think in a case like this, really they should be referred to a psychiatrist for continuing care. So let's move on to the second case in the vanishing time that's coming. Yes,
to the first case.
Yes.
Does ADHD stimulants have a correlation or a causation with psychosis and schizophrenia?
Yes, they do. So it's not everybody, but there is a significantly high proportion of those that are on stimulants that will develop psychosis. We don't know who that will be though. So it does happen, and it can happen. And this change often happens very quickly in adolescence, and which is why you should really screen for it every time you're reviewing patients. Just shifting to a different case now. This is ADHD in midlife. So this was a 42-year-old Aboriginal male who is a professional who was asking about ADHD. He's married with 4 children, no medication. The GP actually had put him on phentermine or Duromine for weight loss last year, and he found that he was actually more productive and could concentrate. And the fog of tasks that he had to do, he seemed to be able to find a clear pathway through it. He'd been seeing a psychologist for many years, who knew him well and was helping him work through a very traumatic childhood that he had experienced, and suggested that maybe he had ADHD. He always thought it was just vestiges of, these are his words, by the way, vestiges of childhood trauma. His wife told him to pass on to me that he's always on the go, can't sit still, cannot watch a movie with her. There were no depressive symptoms, and apropos of the last case, I asked about psychotic symptoms. There's none of that. No psychotic, no suicide attempts, no mood disturbance, no admissions. He had past PTSD symptoms that had improved after attending therapy for many years, and he had minimal ongoing PTSD symptomatology. Next slide, please. His dad left before he was born. His words were that he was abused in childhood, and he described seeing profound violence all around him. His mother had suffered incredible domestic violence at the hands of many men. He described himself as a delinquent from ages 18 to 22. I asked him what that meant, and it was because he was trying to be a bikie. He said he just got into fights, was really doing things that would have accrued charges if he'd been caught. He got his life on track from age 25, went to uni, but really hated every time he had to focus and study and read and assignments. He really struggled through that. Next slide, please. So what other information do you need to assess for an ADHD diagnosis, and to safely manage this patient? So just select the most pertinent in your appointment time that you would do. Oh, this is another one that it's actually meant to be 3 options, but pick the one that you'd want most, and we'll talk about the other ones too.
Mute. Do you mind just expanding on the psychosis point around, is
Yeah.
it directly linked to stimulant medications in the general population, or only those that have an underlying predisposition or another diagnosis?
So stimulant, well, both. So if someone does have an existing diagnosis of psychosis, they're incredibly vulnerable to getting a relapse if prescribed stimulants or taking non-prescribed stimulants, such as recreationally. Also, we know from population studies that ADHD populations that are treated with stimulants are at a slightly higher risk of developing psychosis as a group. And a good example has been that's also been replicated in epidemiological studies looking at, say, cannabis use, where there's a clear dose response.
And is that in children as well as adolescents?
Adolescence is the key time. So the key peak onset for psychotic disorders would be mid to late adolescence. If people are using other drug use, the onset peak shifts forward by 3 years. And so yeah, adolescence is a really crucial time. I'm not so worried about it in children. Adolescents, yes. And young adults, yes.
Thanks.
So yes, quite a few have wanted to explore current ADHD symptoms, psychotic symptoms, going to get a Guernsey as well, and age of onset of ADHD symptoms, which is excellent. Those are the exact areas that I'd like to explore. Let's go to the next slide to clarify that out. So this is really important, is actually ascertaining when the problem started for the person. And we know ADHD is a neurodevelopmental disorder. It starts really from childhood. So from early primary school to now, being unable to sit or focus, procrastinated, very easily distracted, hard to wind down at night, is unable to initiate or maintain life admin. We all have life admin, but he was unable to really get through those things. He commenced high school in more smart classes, and his words, he ended up in the lowest ones. It was never suspended because he didn't want to go home because it wasn't a pleasant place when he was young. Didn't have any drugs or alcohol for the last 20 years, but prior to that admitted to quite significant binge alcohol, cocaine and speed. Let's go to the next slide. So a mental state examination, he appeared to be a muscular man, 118 kilos. When I took his blood pressure, it was really hard for my cuff to get over his very big biceps. His affect was mostly reactive, a bit flat when talking about his childhood. His mood was mostly happy. There's no real abnormalities on mental state examination. I've listed the main things there. And I think if you're reviewing patients, you should probably list at this kind of level of detail in your documentation to show that you have actually asked those things. And certainly there was evidence of distraction and inattention, but no psychotic symptoms, as I've said there. Next page. So what's the diagnosis? And you can select what most applies here. This is a single choice, but actually a couple of answers are relevant.
There is a question in the chat about childhood trauma and if that's a risk factor independent for ADHD.
That is, look, it's not specifically, although we do see ADHD is a vulnerable group that is at an increased risk of different things, not just ADHD itself, but we know that when people have ADHD, they're actually more likely to develop other conditions. So, okay, people have gone very much down the ADHD line, and I completely agree with that from this diagnosis. It's also relevant to say that he did have PTSD in remission. And I think it's important to highlight that he had substance use disorders in sustained remission because he hasn't used any in more than 2 years. Next slide. So what will your immediate management be? Start lisdexamphetamine. And here you can select more than one. You can select as many as you like. So there's 2 stimulants there: order routine pathology, start SSRI, order UDS, motivational interviewing, trial non-stimulant for ADHD. Sorry, Rebecca, I got distracted with the case. What was the question? Did I answer it? I can't remember.
You did. So it was about the so again, essentially adverse childhood experiences, childhood trauma.
It is a toxic effect on the developing brain, and it interacts with genetics in a way that increases rates of a number of problems, not just mental health ones, also physical health ones. We know that people that experience, multiple ACEs end up having poorer physical health. We actually know now there's really good data that childhood abuse experiences can increase the rate of psychotic illness in adulthood, which was an unexpected finding. So yes, it does increase ADHD rates, but it also increases things generally, and that can add to a complexity. Okay. We've half have gone to lisdexamphetamine, half have gone to methylphenidate, 3/4 have gone to routine pathology, which is great. I think that's important, particularly in adults. I think I agree with Sarah, and with children, the need for routine pathology isn't there. But for adults, I think it's worthwhile getting a sense. Oftentimes that no one's done a blood test on them in 10 years. I also do order a urine drug screen because I think it helps demonstrate that a person is as abstinent as they're saying. And in terms of winding them down, his wife was saying he doesn't sit next to her to watch a movie, and he can't be taking a stimulant at 9 p.m. to watch a movie with his wife. That doesn't make sense. You might think about a non-stimulant for that. I've just gone through it here. Yeah, so I would look at starting a stimulant after getting a urine drug screen that's clean, and I would consider using a low dose of a non-stimulant like clonidine to help with that wind down at night. And really, if there's this one, ended up being a more simple case than the first one. But if there's a non-response or psychiatric comorbidity that you're concerned about, please feel free to refer to a psychiatrist. Thanks. I think I'm up to my last slide, which is just some tips from my point of view as a psychiatrist for ADHD. Always explore psychiatric comorbidity. Young people, as that first case demonstrated, can actually change quite dramatically in months. And so a pediatrician that might have been involved, 1 year ago, things might have been very different after 12 months. Always ask about psychosis. Refresh your memory about Schneiderian first-rank symptoms, mood disorder screens. You don't have to ask them 50 questions, but just 3 core ones that can cover that off. Always ask about drugs and alcohol. I think if you're prescribing stimulants, we should always do a pre-treatment UDS. That's my general practice. S8s do require special approval if a person is a drug-dependent person, and that's actually legally defined. It's not actually defined in a clinical sense. And the law says that that's a person who's got an overpowering desire for continued drug use. So I would argue that someone that's using cannabis daily is a drug-dependent person, is legally defined, which requires different approval to the number that psychiatrists would generally use, and now the number that GPs can use once you've got that approval. Remember non-stimulants? I know this is all about stimulants, but non-stimulants are effective and can be actually safer with psychiatric comorbidity, and combinations can be helpful too. Treat comorbid psychiatric conditions first, and please refer if there are any concerns. That's it from me.
Wow, oh my goodness, what an hour and a half. That was absolutely incredible. I am just going to acknowledge that we did answer questions as we went, and there are still quite a number of questions in the chat box. So we will make sure that we go through and get them all answered and out to everybody with an additional information sheet, as well as potentially expanding on, or definitely expanding on, some of the ones that we only covered over briefly in this webinar. I'll pass over to Jasmine.
Thank you so much to everyone for joining us and to our amazing panel of presenters this evening. I just wanted to let everyone know that this is a CPD accredited activity, so please complete the survey that will be posted after the webinar. As Rebecca did just mention, we will send through some information to you following this, but if you also have any questions, you can email us on the email address that is displayed on the screen. Thank you so much to everyone for joining us, and I hope you all have a lovely evening.